Fabulous, thank you. It's actually the other way around. It's Jackie's going to start and then I take the second half, but that's absolutely fine. Jackie, I'll just load up the slides for you.
Thank you very much, Helen. Perfect. Can everybody see those?
Yes.
Yeah, lovely. Thank you. So thank you everybody for coming to this webinar this evening. As we said, we're going to focus on community rehabilitation, and what we'd like to talk about today is the shared vision that the Chartered Society of Physiotherapy has with its members and with other organisations who are all passionate about the benefits of providing community rehabilitation to patients and about the opportunities that it can give to health professionals as well. So hopefully today you'll get a really good overview of how we see community rehabilitation working, the breadth and the skills that you need and that you can develop working community rehabilitation, and about how we're hoping it will look in the future. Thank you, Helen. Next slide, please. Helen's my Chris Whitty slide. Move her on. So this slide looks quite busy, but this is really to indicate to everybody that the Chartered Society of Physiotherapy isn't working on its own when we're talking about community rehabilitation. All of these associations here make up something called the Community Rehabilitation Alliance, and that's a coalition of about 60 health and social care charities which are working alongside a number of professional bodies to further the community rehabilitation agenda nationally. So they're lobbying Parliament, talking to MPs, talking to the Health Secretary, doing everything we can to push the community rehabilitation agenda. Next slide, Helen. And this slide here, we're really looking at how we feel an overall vision for services can work. So if I start at the top and start to work down, hopefully you'll have a look and see how it can all start to fit together. So these pink bubbles at the top are talking about accessibility to services, and one of the key things about community rehab is that we have really good accessibility, and what the CSP and all the other agencies are hoping is that anybody with a rehabilitation need can be referred from any part of the health and social care system or can refer themselves in, and that once they're in that service, they will be seen by the right people with the right skills at the right time. We want it to be seamless so that there's no duplication of work and that you're seen by the people who have the skills to treat you. So once you're into the system, we're talking about having roles from advanced clinical practitioners, which Helen will talk a little bit about later, full multidisciplinary teams utilising health teams, care teams, and third sector support to provide input. We know that health teams can't do it all on their own. I know you all know from working day to day in community rehab just how busy it can be. So we need to think about developing those links with people that are trained volunteers that work in the third sector, local social prescribers. And initially this can take a little bit more time to get those links and to work out processes and ways that how you can move patients through. But in the longer term, it means that the health teams are doing the bits that they can do and they're the experts in with the patients, and that patients are seeing other people later on in their journey when there's people with skills as well, but the right skills at that time. And then as we move down, looking at the 4 circles here, it's all about providing a person-centered approach and a what matters to me approach. And none of us can know that as professionals. It's very difficult to get that from a paper referral or an electronic referral sent from a general practitioner or on a hospital discharge form. And so it's really key talking to that person, working out what they want and what matters to them. And there's no one specific treatment approach that we would advocate. We all know there's a variety of conditions you treat in the community, so there needs to be a variety of treatment approaches, and whoever is best placed to do this and however it's best placed to do this needs to be the way that the patient is treated. So whether that's using a hybrid approach, so partly face-to-face, partly online, whether that's thinking about utilising other venues as opposed to patients' homes or bringing them into day centres or into hospitals, and whether that's working in group settings. We need to think about the best ways that you can provide the services that patients need. And as we've said before, it needs to be really shared decision making and shared goal planning to have your patients on board with what you're working towards. And what we're aiming for in the longer term is for patients to have a supported self-management approach. So a whole holistic approach, which I'm sure you all do every day anyway. And I think that's really one of the skills of community physios, is that you take a fully holistic approach and that you're considering all other factors that might be impacting on that person's presentation and impacting on their ability to take part in rehab. So thinking about psychological factors, communication, cognition, diet and lifestyle. And what we don't expect for 1 minute is for the community rehabilitation teams to be able to solve all of those problems, but to have an understanding of services and where something is impacting on rehab, be able to signpost patients to the right support systems so that they can have support around their rehab needs. And thinking about the outcomes, we want all patients to feel that they can increase their participation in their valued activities, whatever that is, whether that's gardening, walking the dog, whether that's patients of working age. And we want them to have the confidence to be able to self-manage their conditions so that they're decreasing their reliance on services, and we're able to decrease our re-referral rates. And we know that we can let people go happily to manage themselves. We also want the patients to be increasing ownership of their long-term conditions so that they are aware of what they need to do, but they're also aware when they need to come back to us. So educating patients to go away, manage where they can, but to re-refer themselves into services appropriately as they need it. We also really want to think about increasing commitment to physical activity, and whether that's through physios starting patients off and then talking to patients about local community groups, community services, whether that's them using some of the online resources like the Chartered Society of Physios Stronger My Way resources, which is an online portal that patients can access to work through some home-based exercise programs and set themselves goals. However that works for that patient, we would like them to really think about how they can increase their physical activity to prevent further deterioration of any of their long-term conditions. The bits at the bottom are talking really about the wider aspects of community rehabilitation. From the 1st of July, there's been a move to integrated community services and boards, and each of those boards should be looking at their own local population needs and thinking about the health inequalities within their own local areas, and that is going to vary from area to area. So it's for thinking about your own area. If you know there's any particular areas that are high deprivation, thinking about how you could increase accessibility to services, how you could reach out to those patients that we know struggle to access, struggle to keep going and to maintain participation with our services. Some of the integrated community services will be running their own events and their own health equality events, so it's worth having a look at their websites as they set them up, as people get into post, and see what they may be running and see what work streams are going on that you could feed into and that you could sell your community services to. So as we said, it's thinking about all those different ways. It's thinking about in-person, remote or blended delivery, and it's thinking outside the box slightly, that community, yes, we've always thought of it traditionally in people's homes, but can we also think about moving it out into other areas to, as well as increasing patients' confidence with their condition, increasing their confidence to access local communities and to do things away from traditional health areas of treatment. Next slide, please, Helen. and Helen might jump in with this slide, but this slide is talking about the Clear Living Well program, which is designed to improve cardiovascular health. It's starting in August 2022 with the main program delivery starting in January and hopefully completing in July. What its key aims are is to identify patients from primary care network data who are at risk of developing cardiovascular disease and other related long-term conditions, and to work on, it's, I think, Helen, you are going to have to help me out here. It's looking at having services that are, oh, we're jumping ahead.
Sorry, my fault.
That's all right, no problem. It's looking at services who would like to be part of working with these new models of care to proactively care for these patients so that we can prevent further deterioration. And I know expressions of interest are open, and I don't know, I'm hoping that QR code would scan if you wanted to scan it to see a little bit more about the program. I'm not, Helen, you can probably talk a little bit more about the funding around that and where that's happening from.
Yeah, so the National Clear program, it's a really interesting model. It's clinically led. Clear stands for something specific, something clinically led around transformation. So it's a really great example to really support sort of large scale transformation. And if we look back at this slide, there will be elements of this that you're probably sitting there and thinking, well, my service does that. But there will be services out there that don't do any. There will be services out there that do lots, and there will be services out there that do some of this. So really the CLEAR program it's about allowing PCNs to bid for clinically led transformation support from doctors from multidisciplinary teams who are specialized in quality improvement to come in and to support that transformation piece, sort of really using that sort of project management expertise that they have, because recognizing that the skills of the clinician are in the clinical sphere, but bringing in these transformation skills to do that. So I think the funding is all through NHS England, and yeah, it does have its emphasis, as the title of this program says, it does have its emphasis at the moment on cardiovascular disease, but really it's about sort of taking down those silos and trying to promote community services, being able to support upstream before sort of people with long-term conditions become chronically sick and disabled. So it's very much about that optimizing care and minimizing risk. So yes, the QR code should take you through to the CLEAR pages. I think there's only really a couple of PCN funding opportunities that are available. So if you are interested, take it to your service lead and just get involved and get bidding for some transformation support to try and make this work. It's a great opportunity, and the CSP has been very much engaged with CLEAR in planning and setting this up, and it is to reflect that model that Jackie was just talking about there. I'll hand back to you, Jackie.
Thank you, Helen. You can move on to the next slide. Perfect. So I absolutely love this slide, and the reason that we've put this in here is it talks a little bit about things that link together to make truly integrated community rehabilitation. And I think if we look through it, as we said, community therapists are the experts in all-round holistic person-centered care. But what this slide shows is the breadth of specialties that you come across in community rehabilitation and the breadth of skill that you need to work as a good community therapist, and all the different areas where you can develop your own skills or expertise. I know it's traditionally been said that, and we have talked about whether community physiotherapists should be called specialist generalists, but there's no reason that you can't increase your own clinical knowledge or become a specialist in any of these areas, as well as having generic skills to work as a community physiotherapist. So respiratory, aging well, frailty, all of the anticipatory care work, all of the population health work, all of the urgent care response and the discharge to assess, the preventative work, the stroke, the long-term conditions, all come together to make great community rehab. And I think it just shows, as I said, the breadth of skill that everybody who works in community rehabilitation has, which is why I love it. And you're all in that middle section at the center of the flower, providing all of those skills to patients. Next slide, please. Sorry about that. I thought I'd turn that off. Next slide, please. Oh, it's coming slowly.
Let's try it again.
God, sorry, the slide is coming through and my phone also won't be quiet. I thought I had turned it off.
Sorry,
Perfect.
I've just got an unstable message. But
that's all right. Thank you.
Please.
It's come through. Hopefully everybody can see the slide now. So this slide talks a little bit more about the different roles that we would anticipate being in community rehabilitation teams. So the first role is the leadership role, and that's where that could be either a managerial role or that could be a leadership role with a, sorry, the cat is also meowing behind me, with a clinical priority. So what we're hoping is that advanced clinical practitioners roles will be filled by physiotherapists, and there's lots of opportunity out there now for clinical leadership, whether that is looking at prescribing, whether that's looking at advanced care planning, and what that's working under all 4 pillars of advanced practice. So clinical leadership, facilitating education and learning to other members of your team, to volunteers, to carers, to the third sector, and also research. Community rehab pathways and patients have a real opportunity to be able to have audit, research, service improvement opportunities to show the great work that we're doing and to develop those. Oh, we're going back to the other slide. Hopefully the next slide is going to ping back. Here he comes. The other thing when we're talking about the 4 pillars and talking about research is it's really, really important to gain evidence from your service. So we want teams to be able to feel they can gain data from the work that they're doing to show the difference that you're making with patients. So really thinking about what you're collecting, why you're collecting it, and how you can use that to influence and evidence your services and how they're working and how they're demonstrating patient improvement, how you're saving primary care time, how you're able to provide a one-stop shop for patients, how you save referrals on. And we know that particularly with the new integrated community services coming in, I had a great quote the other day, is that without evidence, you're just another person with an opinion. And I think that's lovely. We all know that community rehab services can provide great patient care. We can make a real difference to our patient populations. But if we're going to want to be having our services funded, to have increased staffing, to have increased resources, we really need to have the evidence and data behind us to be able to demonstrate how well we're doing and the difference that we're making. And then moving on to assessment, we're talking about anybody who is capable being able to assess. So whether that's a physio, whether that's an OT, whether that's another member of the multidisciplinary team, and certainly lots of community teams are working really well with having therapy assessment practitioner roles. So band 4 roles where people are going through apprenticeships and are able to carry out some of the simpler assessments and take away those assessments so that the qualified staff can work on assessing the really complex patients. So using your skills and using other people's skills in the right areas. As we said, we want to be able to increase skills of all of the team members. We want everybody to be working at the top of their band and to be able to do as much as they can. We know that helps with staff retention. We know that helps with staff satisfaction. If people are feeling they're being tested, they're being challenged, and that they've got an opportunity to grow within their role. And in terms of service delivery, it's about who's best placed to deliver that personalised rehab programme. It doesn't necessarily need to be a physiotherapist carrying out the physiotherapy. We know increasing numbers of support staff allows clinicians to have time to assess and deal with the complex patients, and then to oversee personalised programmes for patients. We need to think about, again, providing that blended rehab offer. So whether it's some of the treatment being done remotely, whether it's those follow-up, just check-in visits where you think you're just going to pop in to see somebody at the end of treatment, whether they can be done remotely, whether it's carrying out some of the subjective assessments remotely, then we know that they can save time. Particularly, I know the east of England, I'm from Norfolk, it's a very rural area, very similar to the southwest where I work, particularly with the summer holidays coming up. You can spend a lot of time in your car driving around. If we can save time on travel, save money on travel, we can put that into patient care digitally or into different face-to-face appointments. And as we've talked about before, it's thinking about where we have some of those things. So that use of those community settings to demedicalize what we do and increase confidence of our patients to access all the community resources. And this should be within the capability levels of all staff. So with band 5s, with support workers, as long as they have the right competencies and they've been evidenced as achieving their competencies, we want to be offering all staff within our community teams the opportunity to grow and the opportunity to stretch themselves as professionals. And I think that's possibly my last slide before I hand back to Helen.
I think it is.
I've seen a couple of questions. Do you want us to wait and do them at the end, or?
I don't mind, Jackie.
Yeah, happy to do them all at the end, I think.
Cool. Okay. So I'll take over then from here on in. But again, Jackie, do jump in if you think there's anything that you want to add or that I've missed at all. So really what we want from you to think about is, we know that that's a lot of information to take on. It's a lot of information to think about, and you know, we know that you're doing all of that on top of what is already a really stretched sector. But what's really clear, as Jackie's sort of already said, is that we can't just do more of the same. There aren't, you know, numbers and numbers of community physios sitting waiting in the wings to come and pick up, you know, this extra demand that we're going to be facing in future years. So it is all about innovating and doing things differently. And what we want you to do is to really join the conversation and talk to the CSP about what innovations are happening for you locally. And one of the things that I always come across, so another part of my role is to lead on something called the Innovations Database. And one of the things that I always come across when I'm talking to services is that they always tell me that the thing that they're doing, it's not very big, it's not very innovative, and nobody really wants to hear about it. And that's really couldn't be further from the truth. We absolutely want to hear about it, because it's not big transformational change that needs to happen at our level. Well, it does need to happen. It needs to happen at system level. But at our level, it's the small pieces of work that we think about, that we deliver, that releases capacity back into our local systems. And we really want to hear about some of that. And so please do use the Innovations Database. And I've got a slide on it later, to really think through how you can share some of your innovations. And what's really nice about that is that I get to feature every other month on one of the innovations that's on the database. So you could be in frontline. And I'm really sorry, I've got an internet unstable. One of the really important ways that you can do this as a sector across the East, so whether that's the as we would call it as CSP regions, the East of England or the Southeast Coast regions, is to really get involved with your regional AHP teams, both at Health Education England level or at NHS England level. So you'll all have faculties and councils that are really wanting to promote the sort of the AHP workforce. And you'll all be familiar, I would hope, or certainly have heard some noise about the release of the new AHP strategy. So physio forming a really important part of that puzzle. We are the largest AHP workforce, and we do contribute significantly to that community agenda, obviously. So really what I would urge you to do is, if you don't know who your local AHP council chair is, that you go back into your workplace and try and find out. And similarly, try and connect up. Ask the questions about who is in my faculty and what are their priorities, because it's often about workforce development, service transformation, managing health inequalities, and supporting equality and diversity of staff. So really, really important vehicles through which we can start to affect some change. And they're already there. It's just a case of trying to tap into them. So how does the CSP help? Well, there's lots of different things, and there'll be something different for everybody to take away. I'm going to show you the Rehab Matters campaign video again in a minute. And if you haven't seen it, and I know that we're here preaching to the converted, it does always make me a little bit tingly. I think it's an absolutely brilliant video, but it's there for you to use if you need to have a conversation with somebody who is commissioning your service or somebody important that you need to talk to. Then by all means, really use that video. It's so hard hitting. It's absolutely brilliant. We have got a section on the webpage now. I don't know about you. Sometimes the CSP website can be a little challenging to navigate through. But basically, if you go onto the webpage, if you look at the campaigns and influencing tab and you click down there, you'll find community rehab as a distinct section on the website, and there's lots and lots of resources there. I just got a few of Jackie's cat wandering across the screen. It's fantastic. So one of the things that I want to talk to you about is this, and you'll see it here on the right of the screen, the NHS Right Care Community Rehab Toolkit. And this is a physiotherapy services checklist that myself and my colleague designed a couple of years ago. Then the pandemic happened, so it has sat on our website sort of largely unpromoted, but it's brilliant. It's really simple, and all it does is it's a really simple way of walking you through your data, through all of the things that you might want to look for to really understand the state of play of your service. Now, it's called a physiotherapy services checklist, but of course we recognise that in many cases, and as is right, physiotherapy services aren't working in isolation. They're working as part of integrated teams, and that's fine. It's equally as applicable to that. So do go away and have a look at that and use it to really understand where things are, because in any transformation piece, it's impossible to move forward if you don't really understand where you are. And understanding your baseline data, what your service is commissioned to deliver, what your whole time equivalent resource is, and at what band you have staffing is all really important. I don't know about you, but what I always found when I was in practice is that community rehab, we just have another thing, another initiative bolted onto the side of our service. Whether, I mean, I'm going way back in the day now, but whether that was early supported discharge for stroke, whether that was rapid response, they all bolted on to that sort of domiciliary offer that we had, the standard offer, without really taking that sort of higher level view about how everything worked together. And it just made things quite difficult and complex to navigate through. So it's one of the tools that you've got available to really try and help bottom some of that out. Students, always been a bit of a controversy, but had students with us about this time last year, actually, possibly just before, who really put together a fascinating package for us about the student voice in community rehab and what community offers to student visits, and why students who had successful community placements found it really an inspirational sector to work. Now, we all know why that is, and we can all recognise what some of the challenges might be about taking students and Band 5s in the community. But really, if we are going to create that change, we've got to think differently about those early career options. We've also got Stronger My Way. Jackie alluded to it earlier, and I've popped the link to Stronger My Way Hub in the chat already. Do have a look at it. It's something that will really support community services, I think, both in terms of using strength training, advocating for strength training, but also as the signposting resource for patients, for yourselves, for your own families even. We all ought to be doing strength training on a regular basis, and it's very much referred to as the forgotten guideline, and something that at the CSP we really want to change and rectify. We've also got the ICSP network. We've got over 500 community rehab physiotherapists on that network at the minute. It can always be better. ICSP rises and falls with the members. So it isn't something that CSP meddles in, but it is an opportunity and a space to connect. And we really would recommend that you use it and make best use of it. And then finally, our campaigns and regional engagement team have created what we call an influencing toolkit for CSP members. So it's just, again, you'll find it on that webpage, but it's about using your voice as community rehab therapists and therefore champions to really, when you get in front of somebody important, be able to really talk with passion and with drive, and to frame your influencing conversations in the right way. Okay, I'm just getting a little bit of feedback. Can everybody just make sure they're muted? That'd be great, thanks. So, and the reason that it's important to be muted is because I'm about to show you our video. I'm hoping this is going to work. There we go. Now, fingers crossed, I have pressed the right share sound button. But Jackie, you're the one that's on my screen. So can you give me a thumbs up to make sure this plays properly? If you can hear the sound. So I hope that if you haven't seen that already, that it kind of moved you a little bit. And certainly, the CSP's got another one down here, this Never Too Late, which is a bit Christmassy for the hottest day of the year. But I think is another really excellent video that you can use just to showcase exactly why it is what we do. And as I said earlier, none of that will be news to anybody in the room, a virtual room tonight. We all know why we do what we do and the difference that it makes. It's about being able to share that message with other people and to make them sit up and take notice of the really important role that physiotherapists play in providing high quality rehab. So I mentioned earlier about the Innovations in Physiotherapy database and the role that it has in us being able to share our really small scale innovations together. They don't have to be small, they could be your big service transformations, but in all reality, it might just be your simple measures that you're taking. As long as you're using and collecting data and using a methodology, we really want to hear about it, and we want to showcase that for the benefit of other people. Because what we find with the innovations database, and I hope you'll all have found it already, but that we have three, we call it the 3 I's, the 3 things we want from it. One is to inform us of what's happening in practice locally, what you're doing to improve services. We want it to inspire other people to do the same, to really feel like, well, if that's something that was achievable, I don't know, in where should we say, Grimsby, if it was achievable in Grimsby, is it achievable in Chelmsford? To really start to think more broadly about how we share and shape the knowledge that we gather. There's no point trying to start from scratch when we can share some of our intel about what works, right? And then finally, we want to use it to influence. So those really high quality case studies, those really high quality innovations, we want to be able to take them and have them inform CSP policy, so that when we go and talk to key influencing decision makers, ministers, governments, if we even have one, we really need to be able to take your data to them to show them the importance, the breadth, the scope of what physiotherapy can offer in this challenging landscape. So do have a look at it. We've just uploaded all of the VP UK, so the virtual physiotherapy conference that happened in 2020. We've now just got all of those abstracts on. So there's a whole wealth of new and fresh innovations that have just gone on there. An example of it, look, just literally went on the 28th of June, was about this traditional PR class that was been running in Oxfordshire. And they were suffering the classic sort of nationwide phenomena of 40% lack of uptake. So 40% of people who are eligible to participate in pulmonary rehab just not doing it, unable or unwilling to attend. And so they really changed that up a little bit and gave an individualized home exercise program rather than group-based therapy, and saw 10 out of 12 of those people who didn't want to attend or were unwilling to attend or unable to attend. And actually it did have an impact. So it was thinking a little bit differently outside of that, what we might call a traditional model of pulmonary rehab. So that's one thing that's just gone onto the website. And this is the next, which is about improving unscheduled care in Scotland. So really about front door services. So this is just a little screenshot. There's much more detail underneath these innovations. And they're just 2 of what I've pulled out when I filtered for rehabilitation. So lots of stuff on there that you can really get stuck into and think differently. This is very much about, supporting that interface service. So it's not just about community services who are working in community trusts or or what used to be community trusts, or in primary care. It's about the interface with hospital care as well, isn't it? And getting that flow across boundaries. It's always been quite a sticky thing to get right. I think we are making some progress with some of the initiatives that are coming out of NHS England, but there's always more that we can do there. So do have a look. There's lots of really helpful stuff in there, and it might just spark a light bulb for you about something that you might be able to improve in your own service. So this really is all that we've talked about. More of the same just isn't going to cut it anymore. We just do not have the staff to do things the same as what we're currently doing. Even though physiotherapy has a really buoyant pipeline, we just don't have the demand and supply just is never going to level out here. So we're going to have to think differently. So we've kind of created this pyramid, inverse pyramid, if you like, to really think about how that top section, support in staying well. So this is our sort of our self-management tiers, should be the bulk of our population that we're looking to serve. Yes, so that's what we're talking about with Jackie. So really working upstream, so thinking about the self-management offer, getting to potential fallers before they fall. What is our offer? Who is it aimed at? And really starting to think about how do we create that upstream effect that enables people to stay well and stop that sort of downward decline into frailty. Obviously, illness and injury happens. And at that point, yes, of course, we need to still keep our focus very much on the restoration of function. And that's probably where we do a lot of our work already, right? So it's how are we going to make sure that we get that sort of acute specialist input? So whether that's about stroke specialist support, or whether it's about, I don't know, something from another discipline, sort of dietetic support. And we've talked quite a lot, I think, both on Twitter and recently, about the specialty of generalism. And I think it's okay to have that conversation. I think it's really important that we do have that conversation, make some noise about it. I know people feel very differently about how we ought to be describing ourselves in our offer. And I'm really interested to hear what the group thinks about that as well. But how do we make that fluidity of staff happen? Support, is it about having community staff and suspend your disbelief for a moment and suspend your waiting lists and your busy caseloads? But in that ideal world, is it about being able to go and in-reach into hospital and create that relationship and support that rehab right from acute hospital care right out into community? So you support that pathway, so there isn't that changing operation when somebody leaves that hospital door. So we've already seen that in early supported discharge and admission avoidance services, don't we? We kind of have that, but how can we make that, how can we scale that up more effectively? We don't know. But we need to think about ways in which we do that, don't we? And then there's that support again at the acute and community interface. How are we going to do that better? So lots and lots to think about. So really thinking about keeping people well. And then as we come down to in that sort of acuity of illness and ill health and frailty and restoration need, and it's at that point. So how do we best make sure that our rehab skills, our pointy end rehab skills, are where they need to be, without neglecting the rest of the pyramid all the way through? And that's all we've got for you today. But I'm going to stop my share so that we can see the chat and really help and support with any questions. Right, if I do that.
So I have been having a look through the chat for questions, mainly because that community rehab video gets me every time. I thought if I look at the questions, you won't see my eyes filling up with them while I'm watching the video. But thank you everybody for listening. So I've had a quick look through. Rita, Ritu, you talked about your integrated community networks working really well in Croydon, with the opportunity to discuss patients with lots of health and social care professionals, which gives a greater understanding of services. And I don't know whether you want to just talk a little bit more about that, because I think that's absolutely key for patients being with the right service at the right time and knowing who is best placed to treat them. So I don't know if you want to tell, and I know somebody else who was non-clinical had asked for some people to talk about their services.
Hi, thank you. Thank you for the talk. We started, since the national initiative about the integrated community services, Croydon was part of it. And what we found in the initial stages was that it was a real drag just to get different professionals to come into one more MDT and kind of discuss about a particular patient. The way we run it over here, so there is a GP huddle where the GP is involved as well. So there are a different set of multidisciplinary professionals in there, and GP kind of leads it. And then there is sort of a community wing to it, where there is no GP involved. It is everybody from district nurses to like AGUK, so social workers, pharmacists, everybody else is there but the GP. And very recently, so what was happening, it was being led by somebody who didn't have clinical knowledge. Like, it was a non-clinical person called the network facilitator who was leading the whole thing. And it just seemed up until that time when this was happening, everybody was looking at the patient in silos still, despite everybody sitting in the same kind of meeting. Everybody was only thinking, right, as a district nurse, this is what I can do. As a physio, this is what I can do. And then there was new recruitment. So in the last, I think about 2-3 months now, there has been a new recruitment into a band 8 role, which is a very clinical role. And since this role has been created, what I have seen is a real change, because this person can then bring the whole discussion almost together, saying that, right, you are going in, what can you do? Can you have a look at this? And then liaise with this other professional. And then, at that point, can you get involved if there is a need? So it has become much more, clear where we are going with the patient, and a wider discussion. Yeah, I've just found that really interesting in the way we are now looking. And these are really complex patients. They have loads of mental health issues, housing issues, alcohol, drugs. They are really, really complex. In most cases, GPs don't know what to do with them. So I think now we are seeing a real shift in the way we are working in the community, in Croydon at least.
That sounds fantastic. Thank you. Really, really good to hear. And I know there was a couple of other questions. So Joanne, you talked about any particular outcome measures in the community. And I think that's something that's always really, really difficult, again, because of the breadth of patients that you see. So I think it's looking at really, as Helen talked about, your key service priorities, whether you are, and it may be that you use different outcome measures for different groups of patients. But whatever you use, we would always say that a really important part of that is gaining some patient feedback and some patient quotes, because there is nothing like a patient story. If you're presenting to commissioners, or if you're looking to be able to gain more funding or more staffing for your service, the data is great, and you need to have the data there to evidence how many rapid responses you've seen, how many hospital admissions you've prevented. I think patient well-being measures are a great thing to do, because you're showing that you're making a difference to those patients themselves. But to be able to get some patient feedback and some quotes from patients always really personalizes your service. And I think people can then see those stories, see those patients. If they talk about you as a team, you've got a really nice link in there to be able to draw people in and make them remember your service. Helen, I'm not sure if there's anything.
Yeah, I completely agree. I think It's interesting, isn't it? Because I do think one of the measures the CSP is always advocated for, and it crops up every now and then, is the EQ5D5L. And I think when we're talking about coming out of our silos, it's finding an outcome, or it's about finding the measures that work on a population level. And the EQ5D5L does do that quite well. Of course, it has its limitations, but it's also pretty well connected into systems. So if you are using electronic records, it's usually sitting there in the background somewhere that you can get that mobilizing quite quickly. But the thing for me that has frustrated me since the dawn of time, when I became a physiotherapist many years ago, is the idea that we collect outcomes, we do these measures at whatever level, whether that's at sort of population level, at individual patient level, at experience level, and we put them on a sheet of paper in a lever arch folder above the sort of the band 7, the band 8's desk, and there they stay, and we never interrogate them. And I really feel like if you're going to go to the bother of collecting data, please go back and interrogate it and look about what it means and what it's showing you about your service and what those trends are, because otherwise it's just a waste of everybody's time. So we really do need to make sure that you're linking data into that pathway. And I know there's a couple of questions about sort of private providers and their role of private providers in this, and this applies to them as much as it does to an NHS service. Everybody has got a responsibility to collect data to show the influence and the impact of services on what it is that they're delivering. And I completely agree with what Jackie was saying there about the importance of the sort of the qualitative elements as well. I have a little saying that I always sort of live by, which is no stories without data and no data without stories. So it is bringing things to life by being able to merge the kind of sort of numerical and the richness of that other data. But yeah, hope that's helpful. EQ5D5L, that's where we've always gone in the past. I'm not saying it's perfect, not by a long shot.
I think, like you said, it's freely available, which has to be a bonus in these times, doesn't it? The next one, Suzanne, you'd asked about guidance and benchmarking about staffing levels. Now, there isn't really anything, because what it can be is a race to the bottom, and it depends. Community services are so different in terms of population, in terms of what people are able to offer in your team makeup. I know, Nicola, you'd said about having some rotational and static band 5s, which is absolutely fantastic, and we would absolutely advocate for those positions in communities where there is the team makeup to support that. So we would say it really entirely depends on your population and your staffing makeup. Helen, do you think?
Yeah, I agree with you. It's a bit like competencies, isn't it? It's like they become the baseline rather than the aspiration. So what we don't want, well, of course we do want to provide safe levels of rehab, but what we want to do is provide the level of rehab that everyone wants. So it's really difficult to come to a kind of broad conclusion on what that looks like. On the virtual learning, on the virtual learning platform that the CSP has, there is something called CESL. And don't ask me what it stands for, but it's SESL. And it was designed to do that piece. It's not particularly sensitive, and it won't give you a baseline number. I mean, what we would say is look to the evidence, look to the literature, look to the nice guidance to think about where it supports. I mean, there's so few conditions in there. I mean, stroke's the one that stands out, that talks about this number, this magic number against which you can set a potentially create a staffing levels framework, but there's nothing that really exists to think more globally about it. But yeah, I'll pop the link in the chat to the tool on the virtual learning hub. But but take it with a pinch of salt and as a place to start, rather than giving you a pure answer. Yeah.
Fab,
thank you. Justine's found it for us already.
Brilliant.
Well done. Thank you. That's really helpful.
The next question we had, and there was a couple, Joanna and Jane, you both asked about the CSP's view on the growing workplace in non-NHS private community services, and that you're saying that people are wanting to spend more time with their physiotherapist. And for us in the CSP, we're a member organisation for all physiotherapists, whether that is within NHS, whether that's private, whether that's charity, research, education. So we want to support all physios working in all sectors, and there's absolutely no reason that private community providers can't coexist alongside NHS providers in the same way that musculoskeletal physio has for many number of years. We would ask that you do the same things, that you're looking at data, that you're looking at outcome measures, so that you're demonstrating that you're providing a good service to patients. And we certainly have heard of private services where they employ support staff as well, so that there is an opportunity for patients to receive support staff style rehabilitation even in the private sector. So although we focused on the NHS, as that's obviously where a lot of the focus is on changing policy and changing structures and trying to look at a new way of providing community physio, absolutely the CSP is there for community physio. And we have got some information on our website about working together. So if you are in a situation where a patient, and I can't remember what's the term, Helen will tell me, there's a word, concurrent treatment 2 words. There is a section on our website on concurrent treatment. If you are in the situation where your patient wants to have both private and NHS care, about some guidelines and how you can work successfully together. So absolutely, we support private community physiotherapy as much as NHS physio.
Yeah, I'd agree. And I've just popped in the chat there a link to an article that was written a few months ago now called What If? And it's a piece written by a couple of professional advisors from our team who really talk about this kind of barrier that exists between NHS care and private care, and how we can dismantle that really for the benefit of patients. We think, ultimately working together, let's be clear, there is enough work here to go around. We're not fighting over the same patients here. There is more than enough work for everybody. It's about how we bring the sectors together. So, like the model that Jackie shared, what is the role of independent providers in here? What that model doesn't necessarily do is talk about those small sole practitioners, but of course there's a role within there for those members as well, of course. And I think it's just about us being able to have a really sensible, rational conversation about who can provide what in the local vicinity, because as I say, there's more than enough for everybody to go around. And I think we need to stop being as protectionist as perhaps we have been in the past about hanging on to patients. We know potentially within NHS services, my service that I worked in back in the day, it was 6 weeks and that's it. And that's not good enough for a lot of patients. They need more opportunity to go on after. And where there is potential and support for somebody to self-fund that, then why on earth shouldn't they? And why should we be holding them back from potentially reaching their maximum potential just because an NHS contract says that they've had their 6 weeks and that's that? We've got to be able to think more broadly, think differently, and put the needs of patients right at the centre of what we're offering. So I would agree. I don't think we've got it right. That to say, I think the CSP is rightly criticised for being a little NHS centric, and I get that. It's a blind spot for me because it's never formed part of my practice. So I think the more that private practitioners can get involved in these conversations, absolutely the better, because that's how those messages will start to embed in everything that you're seeing and reading from the CSP. It's a big priority.
Thank you. And there's a couple more. Aileen, you talked about transport being a massive unaddressed issue for group attendance, and someone else had said they wish there was an innovation for transport. I would just say really try and think outside the box though. And this is only from personal experience with when I was working within a stroke team in Somerset, and we ran a 10-week life after stroke group at a joint education and exercise group, and we were finding that a lot of our patients were unable to access the group themselves independently. We actually looked at the cost of even sending out band 3 support workers out to those patients to support them over that. This was pre-pandemic, I will admit, because we would probably be looking at remote options now, but we looked at the cost of transport to those patients, of delivering that service individually. And we went back to our hospital League of Friends, and we were very fortunate to have a League of Friends that did have some money, but we put forward a proposal looking at cost of staff transport versus a taxi to do a round robin and pick up 3 patients per week from our local area. And the League of Friends actually agreed to fund our transport on a rolling basis for those patients, and the patients had a contract that they couldn't sort of cancel last minute unless they were unwell. They needed to have signed up and understood that someone else was funding their transport. But certainly we were able to look at that. And Helen, you've said your organisation has a volunteer driver service, and you tap into that to support attendance at your falls groups, which is brilliant. So I think it is really thinking outside the box if you can, and thinking where are the funding streams and where might there be spare bits of money in your local community. And you only know that by sounds awful, I'm on all the local village Facebook groups. I get the parish magazine for the village I live in. I encourage others who live in other villages in the area when I was working in the community to get things like the parish magazine. So that's where you can find out information about volunteer services. A lot of the people that you might want to tap into probably aren't on Twitter. They might not be, you know, approaching the hospital, but there may be a little article in your parish magazine about a volunteer driver service. Helen?
Yeah, I think that's great advice, actually. The other thing that I would say is that as we move towards, again, thinking about the model, we're thinking about where care is delivered, and sometimes it's been the case that, you know, exercise groups or community rehab groups are delivered in a location that requires many of those patients to need transport. But actually what we're thinking about is actually where are those patients geographically, and what is the right location to treat them in. So is there a village hall? Is there something closer than, you know, the local health centre? What makes sense? And don't be afraid to sort of have those conversations as part of this brave new world. It's about we've had conversations with, I think their name's gone out, is it called UK Active? I think they're called UK Active, and they're talking about they run loads and loads of gyms all over the country, and they're empty during the day because everybody's at work. So it's about making best use of your community assets and really thinking about what those community assets are. I believe England may have just scored because it's just gone balmy in the next room. For those of you following the Women's Euros, sorry about that. I hope that's not a spoiler. I could be wrong. But yeah, really thinking about where those sort of community assets are locally as well. Now, that's not going to change a great deal of the problem, but it's all those small things that will add up to help. Yeah.
I think that was it for questions in the chat. Patricia, you had your hand up. Was there something that you wanted to ask?
No,
it seems she put the hand down.
It's gone down. Yeah. Fantastic. Wonderful.
Yes.
Yeah, I'm just
Okay,
going back
so
through the chat. I think we've got everything. Yeah.
yeah. Thank you very much. Helen and Jackie. That has been brilliant. Before we wind up, I'll just ask healthy. Obviously, that's a big thing that everyone is trying to tackle, both in health and social care and in other areas. So us as community therapists, community physios, what would you say is our role? What can we do? What and people can share what they're doing as well in the chat. Yeah, what are we doing and what could we do to contribute towards reducing health inequalities?
I think a lot of it is about knowing your local population. And we had this, Helen and I were part of a working group at the CSP last week looking, and we were saying that the new integrated community services and boards have a lot of data and a lot of information about health inequalities, and it's finding out whether you can access that data, because a lot of you don't know what you don't know. You don't know people who can't access services or who aren't accessing services. So if there is somebody else, and this is, the work shouldn't have to happen twice. If there is somebody, if there's a health inequities or inequalities team within your new integrated community service, have a chat with them, open up those lines of communication, ask if you can see their data for your local area. Data needs to be shared for everybody to make best use of that. So I love that, Vicky. As part of behaviour change and motivation of participants in a falls group I used to run, I gave the homework to find out what exercise or activity groups were available within a 5-minute walk, 5-mile radius or 5-mile drive from their home. That's wonderful. Giving patients responsibility. I love it. Is there anything else that anyone else is doing?
Sorry, thought I was off mute then. Sarah, you've direct messaged me, but I think it was a more general point. So I'm going to raise it here. And you're absolutely right, because what you say in your message is that men are really reluctant to join group classes. And aiming something at this group is an important consideration. And certainly that was something that I looked at back in 2009. I was working at Addenbrooke's in an AHP role around life after cancer, living well with the side effects of cancer treatment. And it was very much men were a missing group. and it was about us going to men. So where do men go? Men go to the pub, men go to the golf club, men go to football clubs. So it's about where are you going to share your messages about what is available. And I think it's really important that, you know, we think about who our local populations are, as Jackie says, and really frame it to that. So I mean, certainly when I worked in central London, we had I lived and worked around Finsbury Park, so it's a really significant Muslim population there. But actually working with faith leaders was a really important part of the step of what we took, because, you know, it's quite it can be volatile at times to work across boundaries where communities are feeling very isolated. You know, particularly at the time I was there, it was at a heightened tensions, I think fair to say, around that time. So it was very much about using the local staff, the local faith leaders, the local community groups, the local community leaders to really support breaking down some of those barriers between health services and the populations that we were looking to support. Yeah, I think that's what I would say. I think, Justine, you're absolutely right, actually, on that point there about checking records to see who we're seeing. One of the things that I find really interesting at the moment is I'm looking at some long COVID data, and long COVID, according to well, not according to, it's self-reported data on the ONS website. And what we see in that data is that it's white women of working age who form the majority of the population with long COVID. But we know that it's the Black and minority ethnic populations that were initially certainly the most affected with COVID. So there's a disconnect there. And what we could do is look at that data and just say, oh, well, that's truth, right? But because it's self-reported, what we need to understand is who is not self-reporting. So it's really about looking at the gaps in the data and look really critically across your data sets to see what's missing, what's absent.
Thank you, Helen. Ritu's hand is up.
Well,
Ritu, do you want to unmute?
I know, I just thought I'm going to share, like, you know, in terms of the health inequalities. So during the COVID period over here, there was a role created, a role called the community builder. And one of the roles or one of the tasks that they were doing is people could approach them to set up their own sort of business idea in the sphere of exercise, you know, of trying to improve physical activity overall. And one of the groups that was not participating in online or, well, in online, any sort of initiative, were people who were veiled, you know, people who had some sort of face covering, who had hijabs, females. And there was actually a female from their own community who said, I'm going to create a group of exercise, like where we did exercises, but everybody was allowed to wear veils, and, you know, nobody felt out of place, and men would not be allowed into this group. And she has actually seen a growth of people willing to participate in exercises just because she created a specific group where she said, right, you're welcome. So I think it does make a difference, recognizing those differences.
Brilliant. Thank you, Ritu. Unless Helen and Jackie want to comment on what Ritu has said.
No, I think it's really important. And again, I think this is why health inequalities is just one reason why the diversity of our workforce is really important, because allowing people to see healthcare practitioners who you know, who come from similar backgrounds, whatever that background is, but being reflective of local populations. And that's why it's so important that we get the intake into services right, that we look at our recruitment, and we look at our unconscious biases, and we look at all of those things, and we do that really bravely and with great vulnerability to make sure that actually we are sort of removing that bias from our systems, so that our local populations do feel that they have access to a workforce that reflects them. And there will be some way to go on that, obviously. That will take time, but it's the commitment that's there. I think that is the fundamentally important thing, and we just need to make sure that the commitment to that doesn't slide, really.
Brilliant. Thank you so much. Thanks again, Helen and Jackie. This has been an amazing talk about community physiotherapy. Thank you for encouraging us to collect data, and not just collect data, to go back and look at it and see how we can use it to lobby for more support for our services. You also encouraged us to think about what we can do with different, with other team members, like the rehab support workers and other professionals, and the fact that we don't have to work in silos. Thank you for pointing out, I need to find where I wrote that, about the innovations We need to share the innovations that we are doing. We don't have to despise anything. We might think that it's small, but let's share with each other and learn from each other. There is no need to reinvent the wheel. So if somebody wants to do something different or to change something, then we can still look at the CSP website on the innovation section and get some learn about what other people are doing and see how to use that. And thank you for pointing out that without evidence, we are just a person is just another person giving an opinion. So we actually need the evidence to help us. And also we need to continue thinking about the blended approach. So different ways, if we are going to do face-to-face or use the virtual world and yeah, different things. So thank you so much for all the information you've given us, and also the CSP resources. So yeah, I hope we'll all remember to keep checking the CSP website and using the resources that are available to us. So we are very grateful once again. The Agile East Committee, we are grateful that you honored our invitation and you have put in so much effort into this talk. And yeah, thank you for answering all the questions. And if anyone has any more questions, please, Jackie and Helen, they can be contacted. They'll share their emails in the chat if they can, and also they are on Twitter. You can find them. We'll share their details, and also you can contact them through the CSP website. So thanks also to the Agile team, the Agile National Executive team. Suzanne, our chair, is here, and many thanks to the Agile East Committee. So thanks everyone for being here. You've been awesome. Thank you for engaging. And I think it's okay for me to say, have a good night, and hopefully we'll see you again soon. So we have the second part 2 of the Not Just a Community Physio series coming up soon. So the date will be communicated. Keep an eye out for it. It will come via email, and also you'll find it. You'll find it on social media. So yeah, thank you very much. Take care.
Thanks, Justine.
Thanks, Suzanne.
No problem. I'll get the